Hello and welcome to this Pro-CE podcast. I'm your host, Robin Black. Today's episode features a discussion on key points regarding the use of MRAs in patients with type 2 diabetes and CKD. This episode is a part of a larger educational program titled Understanding the Role of Mineralocorticoid Receptor Antagonists and the Impact on Patient Care in Chronic Kidney Disease and Type 2 Diabetes. During this podcast, Dr. Diana Isaacs, an endocrine clinical pharmacy specialist and the CGM and remote monitoring program coordinator at the Endocrinology and Metabolism Institute at the Cleveland Clinic in Cleveland, Ohio, and Dr. Joshua J. Neumiller, Vice Chair and Alan I. White Distinguished Professor in the Department of Pharmacotherapy at the Washington State University College of Pharmacy and Pharmaceutical Sciences in Spokane, Washington, summarize key points from their live presentation on this topic, including an overview of CKD and type 2 diabetes, guideline recommendations for treatment, evidence for use of MRAs and their place in therapy, and the role of the pharmacist in caring for these patients. For more information about Dr. Isaacs and Dr. Neumiller, and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Isaacs and Dr. Neumiller have to say about MRAs in patients with CKD and type 2 diabetes.
Hi, my name is Josh Neumiller. I am a pharmacist and diabetes care and education specialist on faculty at the Washington State University College of Pharmacy and Pharmaceutical Sciences. And it's a pleasure to be here today talking about some of the highlights from our presentation that was presented at the APHA annual meeting about diabetic kidney disease and understanding the role of mineralocorticoid receptor antagonists and their impact on patients with CKD and type 2 diabetes. I had the privilege of co-presenting with Dr. Diana Isaacs, who's going to kick off our discussion here about some of the key points from our presentation. And we'll start off talking about kidney disease and the importances of this as a diabetes-related complication. Diana?
Great. Thanks so much. Yeah, I'm Diana Isaacs. I'm an endocrine clinical pharmacist, and I also am the CGM and remote monitoring program coordinator at the Cleveland Clinic. And yeah, we had a great presentation and discussion. We started it off by just doing an overview of kidney disease and diabetes. And the thing is, unfortunately, people with diabetes are, there's a very high prevalence of having kidney disease. In type 1 diabetes, it's estimated around 30% have kidney disease. And in type 2 diabetes, it's estimated that actually 40% have it. And the thing is, a lot of people don't know that they have kidney disease. Either they weren't tested for it or they were, but nobody has communicated to them that, they have kidney disease. And one of the things that we do know is that glycemic management is really closely associated with kidney disease, meaning that people that have higher A1Cs are more likely to have kidney disease and have markers like albuminuria. The reason why we care so much is because, unfortunately, kidney disease is also really closely associated with cardiovascular disease. And so people that have diabetes and kidney disease have much higher rates of other things like heart failure, strokes, peripheral vascular disease, even death. So, of course, it's so important that we recognize it, we check for it, and that we treat it. And one of the areas that I've noticed that there's some, confusion around is, well, how do you really test for kidney disease? And we have really two major ways that we do it. We have kidney function, which we measure through the estimated glomerular filtration rate, or GFR. And that's a lab test that we can check by checking someone's serum creatinine. And we have different stages based on that, based on what the GFR is. If it's under 15, stage 5 versus, progressively when it's higher than that. It could be anywhere from stage 1 to stage 5. But what a lot of people, I think, don't know is that kidney damage is actually measured by what's called albuminuria, which we can check through a urine albumin to creatinine ratio, which is really it's a spot urine test that's looking for that ratio of albumin to creatinine. And this is a marker of kidney damage. And so people can have albuminuria, but actually have a normal GFR and vice versa. But this is really important because if someone has albuminuria, that means that they have kidney disease. And so we want to take action to be able to treat it and reduce the risk of any complications, and especially with that association of cardiovascular disease. And in terms of the screening, really anyone with type 2 diabetes should be screened at diagnosis. And then generally we look for at least 2 out of 3 specimens that UACR over a 3 to 6 month period. If those are positive, meaning they're over 30, that means that a person has albuminuria. With type 1 diabetes, we can wait 5 years after the diagnosis. That is the recommendation for diagnosing everything. And then the KDIGO guidelines have a heat map based on, someone's staging of GFR and albuminuria to determine, someone's risk. So that's, very helpful to know. One of the areas with kidney disease that is important is that we see is there's actually this mineralocorticoid receptor activation. And the mineralocorticoid receptors, they regulate gene expression through cofactor recruitment. But in kidney disease, there's actually multiple factors that overactivate these mineralocorticoid receptors, which can lead to inflammation, fibrosis, and really just negative effects on both the kidney and the heart. So this has become kind of an important area of interest. How can we target this mineralocorticoid receptor to really improve the outcomes for people with kidney disease? And I know I've done a lot of talking, Josh. I'm curious to hear your thoughts about this, and also, kind of, well, what do the standards of care say, and what is the treatment for kidney disease?
Yeah, thanks, Diana. Excellent background, and I think you brought up some really very key points. Certainly one being that, unfortunately, these individuals are often under-recognized, underdiagnosed, and unfortunately don't receive recommended therapies that both slow progression of their kidney disease and mitigate their cardiovascular disease risk. And to your point, with the measurement of albuminuria, it's really been stressed within the guidelines of the importance of doing that to make sure people are caught early, and we can hopefully prevent not only progression of kidney disease, but also use that as a marker of cardiovascular risk, because we know that as albuminuria increases, the risk of these people with kidney disease having adverse cardiovascular outcomes goes up dramatically. And certainly the standards of care from the American Diabetes Association, as well as recommendations from KDIGO, as you mentioned, are really stressing use of these kidney and cardiovascular protective therapies. And also talking a little bit about some of the residual risk that we can see in these individuals with current therapies, which, as you noted, really leads towards investigating how we may be able to slow down the train and stop some of this oxidative stress and fibrosis and things that can actually progress kidney disease, and whereby antagonizing that mineralocorticoid receptor may contribute to some benefit. So this year, the 2022 ADA Standards of Care, as you're very aware, Diana, serving on that committee, was one of the first guidelines, if not the first guideline, to recommend the new nonsteroidal mineralocorticoid finerenone as a potential intervention to mitigate kidney progression and also cardiovascular events in people with type 2 diabetes and kidney disease. But maybe to take a step back, if we look at some of the general recommendations for comprehensive diabetes and chronic kidney disease management, certainly we have to look at the whole patient and consider a holistic approach to their care, which includes optimization of lifestyle, making sure these individuals are engaging in exercise and physical activity, eating healthy to the best of our ability, really tapping into our nutrition and dietitian colleagues to make sure these folks are getting medical nutrition therapy and optimizing lifestyle. Smoking cessation for those that do smoke tobacco, of course, is very important. And also, as you said, how blood sugar and high blood pressure can certainly drive development of particularly microvascular complications of diabetes. All these guidelines, KDIGO, ADA, really stress the importance of optimizing glucose control based on individualized considerations, as well as blood pressure management and also lipids. In terms of specific therapies, renin-angiotensin system inhibitors, ACE inhibitors, and ARBs have been a standard of care for 30 plus years. So really the guidelines stress utilization of these, of RAS inhibition, of course. Unfortunately, to expand on the point you made earlier, Diana, about these individuals being under-recognized and underdiagnosed, use of even ACE inhibitors and ARBs is incredibly suboptimal in a lot of these individuals who should be on ACE-ARB therapy, unfortunately, are not. And some of that, I think, has to do with maybe lack of monitoring of albuminuria, to your previous point. Beyond that, the guidelines also recommend use of SGLT2 inhibitors. We, of course, know that these glucose-lowering therapies, some within the class, have demonstrated benefit in dedicated kidney outcome trials for progression of kidney disease and also helping with cardiovascular health as well. And so with canagliflozin, dapagliflozin, we have the Credence and DAPA-CKD trials, respectively, that have shown really dramatic benefit on kidney outcomes. And we now know that the EMPA kidney trial with empagliflozin has also been stopped early, as was the case with the first two trials, due to overwhelming benefit. So it appears very well to be a class effect that these help in diabetic kidney disease. And as was seen in the DAPA-CKD trial, even those individuals included in that study who did not have diabetes also derived benefit from SGLT2 inhibitor therapy. We also have GLP-1 receptor agonists and some ongoing evidence with those based on cardiovascular outcome trials where they had secondary kidney outcomes, progression of quote-unquote nephropathy in those trials, signal for benefit with some of our longer-acting GLP-1 receptor agonist therapies as well. And there's an ongoing trial with semaglutide called the FLOW trial, which will answer that question specifically in a dedicated kidney outcome trial that enrolls people with diabetic kidney disease. And as I mentioned just briefly before, now the ADA does recommend finerenone, a nonsteroidal mineralocorticoid receptor antagonist, as an additional option by itself as add-on to background optimized ACE inhibitor ARB therapy to improve kidney and cardiovascular outcomes. Certainly stands on its own in terms of benefit, and certainly as an option if people cannot take SGLT2 inhibitors for whatever reason due to tolerability or other factors. But Diane, I know you, as a member of that committee, maybe you'd want to speak to some of the major changes that you thought were notable this year within the guidelines.
Yeah, well, thanks. That was a great overview. And I just want to add, I'm following in your great footsteps because I know you served on the committee for 4 years and even chaired it before I was on it. But yeah, this was really a big year, lots of changes. In fact, CKD got its whole own chapter. Previously, CKD was combined with the other microvascular complications that can result with diabetes, but now CKD is its whole own section. And that's really because now we have all these therapies. We know SGLT2 inhibitors have great data. We're seeing that with our GLP-1 agonists. And of course, now we have this new class with finerenone. Also within the algorithm itself, over the last few years, CKD has been separated out, but there's a little bit more specific guidance in terms of, well, what do you do, if someone has CKD and albuminuria, then in that situation, preferably an SGLT2 inhibitor would be the agent to start. And then, of course, as an add-on, you can add a GLP-1 agonist versus if someone does not have albuminuria, then, adding a GLP-1 or SGLT2 inhibitor with that proven cardiovascular disease benefit. The other, I think, big change for this year is that with the first line therapy, which has historically been metformin forever, not forever, but almost forever. But this year, the language says, first line therapy really depends on comorbidities, patient-centered treatment factors. And while it generally can include metformin, it doesn't have to include metformin. So if someone has CKD, you don't necessarily have to start with metformin. You can go straight to that SGLT2 inhibitor or GLP-1 agonist. Also being mindful, of course, about using the other therapies like the ACE inhibitor or the ARB. That should really be a standard. And then with that new recommendation about patients with CKD who are at increased risk of cardiovascular events, adding that non-steroidal mineralocorticoid receptor antagonist, finerenone, is recommended to reduce chronic kidney disease progression and cardiovascular events. And that is actually a level A recommendation, which is that highest level. So that's a notable change. And then another big one was this recommendation that in patients with chronic kidney disease, so those who have greater than 300 urine albumin, that the target should be a reduction of 30% or greater urinary albumin. And that's recommended to really slow the chronic kidney disease progression. And so that's new, and that's important because, the ways to do it are through agents like the mineralocorticoid receptor antagonist. So those become really important targets in therapy. And Josh, I'm kind of curious because I know in our presentation you had presented some data about kind of the under-prescribing of some of these agents, like ACE inhibitors, ARBs, SGLT2 inhibitors, finerenone. I'm kind of curious, like what you see in your practice.
No, thanks, Diana, and I appreciate that. And one thing I wanted to just reemphasize, I really appreciate that you brought up some of those big changes this year. The guidelines have been evolving really quick, and to your point, with that recommendation to really target a 30% reduction in urinary albumin, I think that's an important recommendation for pharmacists to be aware of, because as we recommend addition of these therapies, it gives us a justification for those recommendations versus, where the perception might be that, we're adding on a lot of medications in a given patient and, what's the additive benefit? Now we have this target of, well, if we start somebody on an SGLT2 inhibitor, they have that risk reduction. But if we don't see enough urinary albumin reduction, that could be a justification of potential addition of finerenone to really meet that albuminuria target. But yeah, thanks for the question, Diana. I have the privilege of working with a research group in my area in Washington, in the state of Washington, and also with UCLA in Canada. We're involved in a big registry called the Cure CKD registry, and we're able to look at use of some of these medications. And yeah, in one of our recent analyses in over 600,000 individuals with chronic kidney disease, they were actually more likely to be receiving nonsteroidal anti-inflammatory medications or other potentially nephrotoxic agents like PPIs and other drugs than they were actually taking ACE inhibitors and ARBs. And of course, there might be reasons people might not be on those medications. But to me, it was pretty eye-opening that there is a great need for really evaluating these individuals and making sure they're on really standard of care. Because unfortunately, a lot of the really truly evidence-based medications that can prevent progression are not being utilized. And so it really begs the question, as we have all these new therapies and great data, when we're not even optimizing use of our standard of care for over 30 years, how can we really change the way we think about healthcare delivery to make sure these individuals are getting the best care possible? And certainly in my clinical practice, where I go into people's homes and do medication evaluations, very common to find that these individuals with chronic kidney disease taking nonsteroidals and other over-the-counters that probably aren't doing much for their kidneys and overall cardiovascular health. What about you, Diana? You seeing similar things in your practice?
Yeah, it just seems, well, yes, a lot of people are on NSAIDs and medications that can be nephrotoxic, unfortunately. So that is definitely the first step. But I find it just takes a while when medications are newly approved. It seems to take a long time to kind of penetrate general practice, especially in primary care settings. I mean, we've had the SGLT2 inhibitors now since I think it was 2012. And I feel like it's just now, like 10 years later, we're finally seeing increased uptake and everything. And so being that, finerenone just became FDA approved in 2021, that, it's not going to kind of happen overnight, that people know there's new medication options. And hopefully it helps that, now the standards of care have incorporated that. So hopefully we will see, increased uptake of these agents. And I think that's where there's a huge role for the pharmacist in the management of kidney disease. First, just being with, the identification. I mean, even pharmacists, regardless of the setting, whether you're working in community, in AM care, in hospital, making sure that people are at least been screened, that, have they had their GFR assessed? Have they been checked for albumin, urea? And then if they have, if a person has kidney disease, letting them know about that and knowing the actions they can take, especially the lifestyle changes that you mentioned, because those are things, we want to encourage and we want to make sure people are aware of that. Also, we know diabetes management and also kidney disease management. I mean, it's a team sport in terms of, there's multiple disciplines that can be involved because it increases the cardiovascular risk. So you can have cardiology involved, you can have nephrology involved, primary care, endocrinology for the diabetes. And so it's all kind of working together how we can optimize that care for the patient. And that communication so we can make sure we're using these agents. Sometimes I see in practice that, someone goes to cardiology and they're like, oh yeah, we should use these SGLT2 inhibitors. Oh, but the patient's on insulin. Gosh, I don't know. How am I going to adjust this insulin? What am I going to do? And so that's where that team approach of saying, oh, okay, let's work together. This is how we can adjust the insulin doses to safely add these medications, I think can really, really help. And we know with adding agents like the ACE inhibitors and the ARBs, as well as finerenone, potassium can increase. And so that's something we should be monitoring, making sure we're checking those labs. Typically we want to check 1 month after starting finerenone. And so making sure people are getting those labs and following up and everything. And then, of course, with many medications, there may be dose adjustments that are needed as GFR decreases. And so, the pharmacist has an important role there to be able to guide how the medications should be adjusted as well. Curious if you have any thoughts to add, like on the team-based care or anything else.
Gosh, I think, you really hit the nail on the head, Diana. Really, something that stood out in your comments to me is that delay in uptake of these medications. I certainly agree. There's always a little bit of lag, and there's early adopters, but it does take some time for, the guidelines themselves and what they say, and also the new data and new medications to really penetrate into primary care where the majority of these patients are receiving care for their diabetes and kidney disease and cardiovascular disease in some cases. So again, I think pharmacists are really uniquely suited to educate patients, certainly, but also educate other members of the healthcare team about these new medications and really where their role might be. And to your point, we're making sure people are being followed up appropriately, following potassium, kidney function, and all of those factors to optimize their care and safe medication use as well. And maybe with that, I thought I would just throw in just a few key points about finerenone for the listeners, where they may be able to communicate that to any of the other members of the healthcare team that they may be working with. So finerenone, it is a non-steroidal mineralocorticoid receptor antagonist, as we've said. It is a little bit different than what we traditionally think of with steroidal MRAs like spironolactone and eplerenone, and are important differences to consider. Finerenone is considered to have high potency like spironolactone, but has greater selectivity for the M mineralocorticoid receptor, and doesn't have active metabolites. And its unique pharmacologic profile results in its ability to address that mineralocorticoid receptor overactivation in chronic kidney disease, with really a reduced risk for hyperkalemia, at least when compared to spironolactone. And really where this agent has made its way into the guidelines is based on 2 large outcome trials that were performed with finerenone in people with type 2 diabetes and CKD. One was the Fidelio trial. It had a primary composite kidney outcome. So that was really a kidney outcome trial by design. And there was also a cardiovascular outcome trial called Figaro. So they were pretty intelligent in their overall design, where they had 2 different studies in the same population, where one was a cardiovascular outcome trial, and the other one was a kidney outcome trial to ask both questions directly. And both trials had statistically significant benefit of finerenone over placebo. So Fidelio, that was the kidney outcome trial, about an 18% risk reduction for its composite kidney outcome. And for the cardiovascular outcome, again, statistically significant 13% risk reduction. Other key findings, this drug did reduce albuminuria with treatment. So again, thinking about that importance of albuminuria reduction in people with kidney disease to slow progression. It did have about a twofold increased risk for hyperkalemic events, as you mentioned, Diana, less than we would traditionally think with spironolactone, but it is still a consideration. And so people who had higher baseline potassium, lower baseline kidney function as measured by eGFR did have a higher risk for hyperkalemia. So with this medication, really important to test both of those at the onset of initiation and then periodically thereafter. And the general recommendation is to monitor potassium 4 weeks after starting, or dose adjustments and throughout treatment really to guide therapy. And then really thinking this medication is metabolized by CYP3A4. So there are some CYP3A4 interactions to consider that we discussed in a little more detail in the presentation, which will be accessible if you want a little bit more detail on the medication. But Diana, any other pearls you have on finerenone?
No, that was really great. Yeah, I think as pharmacists, I just reiterate the drug interaction with the CYP3A4, because then you would want to avoid potent inhibitors. And, that includes things like erythromycin, diltiazem, grapefruit juice. So those are, good counseling points for patients. And then the actual FDA approved indication is really important and powerful. So because of these outcomes that you just heard, you just explained, it's indicated to reduce the risk of sustained GFR decline, end-stage kidney disease, cardiovascular death, non-fatal MI, and hospitalization for heart failure in adults with CKD with type 2 diabetes. So why I'm reiterating that is because this is not like a surrogate drug that's just like only reduces albuminuria. This hits on those big things, on the cardiovascular disease. So that's really, really powerful. And that is why the guidelines were so strong with that level A recommendation about the use of it. So yeah, and I encourage people to definitely listen to our presentation, because you did such a nice job of really going through the data and showing, how they got to be at these outcomes.
Yeah, thanks, Diana. And I really appreciate you stressing the indication, because, these were well-designed trials with very important clinical outcomes, and this medication did make a difference. And, as we kind of finish up, I just want to let the audience know that the guidelines continue to evolve. We have the American Diabetes Association scientific sessions coming in about a month or so. And there are some publications in development. I know the committee Diana works on is looking at the new data that has come out with finerenone in recent months since the last update to the guidelines. And KDIGO is working on updating their guidelines for diabetes and CKD. So this is definitely an evolving story. And I certainly anticipate a little bit more specificity regarding the role of finerenone as we learn more about it in clinical practice. So, gosh, Diana, it was really great presenting with you and certainly connecting with you again for this overview podcast.
Same here. It's always great discussing these things with you. Thanks so much.
Thank you.
Thank you very much to Dr. Isaacs and Dr. Neumiller, and thank you to our listeners for joining in. As a reminder, to view the full program, click on the link in the show notes for this episode. As always, thank you for listening.